We're now ready to start the third of the sessions on menopause and midlife health. Dr. Marcia Stefanick is professor of both medicine and obstetrics and gynecology. She's had leadership roles in all of the Stanford Women's Health initiatives, including the Cardiovascular Institute, Women's Health Heart Program, and the Cancer Prevention Programs. And I think that if any of you have been alive and watching the news over the past 5 years, you've probably all heard her name in association with the Women's Health Initiative. This was a study that was performed at multi-institutional study, and Dr. Stefanick was the principal investigator for Stanford. She has interests in hormone and sex difference research, and she will be telling us about this today. She has so much information she's going to be telling us that she will not have a question and answer period immediately following this, but she will be around all afternoon and between the sessions, so she'll be able to answer questions at that time. But she's going to talk to us today about factors in midlife and menopause health. Dr. Stefanick.
Thanks, Linda. Okay, so menopause and midlife health. I'm going to start with the midlife health part of this. And start out with focusing on the age group 40 to 59, but when we talk about midlife health, that obviously depends on where you are in your age in terms of what you want to negotiate. And basically this is plus minus 5 years. We look at 35 to 64 as kind of the midlife at this point. And what I'd like to do is just kind of home in on the fact that we are starting to die from chronic diseases in this midlife period, and most importantly, we need to be preparing for the next phases. So what you see on this particular graph is that heart disease is the leading cause of death of women even in this midlife group. And then we have breast cancer and lung cancer, and at the end, colorectal cancer, so that by the time you put those three big cancers and other cancers together, total cancer exceeds heart disease. But as a single cause, heart disease exceeds each of these individual cancers. And I also want to quickly point out that accidents kill as many women in this age group as does breast cancer, and we really could do a lot more in preventing accidents. But what I want to do is just very quickly hit on the midlife health issues. So something to realize is that at age 55, we suddenly are considered to have a new risk factor based on age for heart disease. I think most of you are aware of the cholesterol issues that we want to have as low levels of the LDL, the bad cholesterol, as possible, and as high levels of HDL as we can. High blood pressure is a risk factor. Cigarette smoking not only is a major risk factor for heart disease, but also for lung cancer, which you saw was very close to a cause of death in this age group, as is breast cancer. Diabetes is actually something that if a woman has diabetes, her risk of heart disease is much higher than if a man has diabetes, and also if she's already had a heart attack. The other set to just home in on is genetics. Clearly, we can't change that, but it is the case that if your father had a heart attack before the age of 55 or your mother had a heart attack before the age of 65, that's considered premature, and it does suggest that you may have risk. Similarly, brother and sister, first-degree relatives. Lifestyle factors are huge. They do relate a lot to the previous risk factors that I talked about. So when we talk about sedentary status, obesity, diet, particularly high saturated fat, all of those affect the risk factors that we mentioned on the previous slide. And metabolic syndrome is really having a constellation of these risk factors. The other one that I want to just hit on is breast cancer risk. There's actually a really nice little risk calculator that you can go into at this website that's on that's a cancer website that doesn't start till you're 35. So it starts right at where we consider midlife starting point. And so if you are 35 or older, then you can enter and get your 5-year risk for breast cancer that looks at the age of your first menstrual cycle, it looks at the age of your first live birth, the number of first-degree relatives that have had breast cancer, and if you ever had a breast biopsy, even if it's a negative finding, it's still the fact that something unusual was in the breast does seem to be a risk factor. It also addresses race and ethnicity. Now, what's not here that many people talk about is the age of menopause, and what I wanted to do is use this as my segue to menopause and make the point that if we look at how age relates to menopause in terms of risk factors, one thing that you'll see on this slide is that there's no effect of menopause on the risk of heart disease. So this is a big fallacy. Many people have this idea that women are protected until they go through menopause and then they lose all protection. But when you actually look at the data, there's absolutely no effect or no relationship to menopause and death rates for heart disease, but there's a very significant one for breast cancer. And it's actually the case that when you go through menopause, your risk of breast cancer actually, even though it's still going up because of age, it actually levels off and is not as steep as it is going into the menopause. And this relates to our endogenous estrogen. Having estrogen on board before we go through menopause does increase our risk for breast cancer. So let's move on to menopause and this transition. First of all, I want to be sure that you're all aware of a term called perimenopause, which is a big chunk of time, and I'm going to show another slide in a moment for that, which is where all kinds of changes are starting to already appear in the endocrine profile and in your experiences. Women start to get irregular menstrual cycles, they start to get some of the vasomotor symptoms, they have dryness and itchiness in their urogenital area, there is a transitory bone loss, and so all of these things are giving you the signal that basically your estrogen levels are slowly dropping and a change is about to occur. Now, you can go through menopause very abruptly by having a surgical removal of your ovaries. If you don't have estrogen on board, then basically you will go into an abrupt menopause. So we can have natural menopause or surgical menopause, but I do want to remind you that it's removal of the ovaries. It's not a hysterectomy. The uterus is not participating in a lot of these experiences. So I mentioned the menopausal transition. We used to have this idea that you were premenopausal and postmenopausal, as if you fell off a cliff. In fact, it's a gradual thing, and it's arising from the fact that we're born with all the eggs we're ever going to have, and we start losing them. Actually, we lose a lot even before we're born. We start losing them again when we go into our first menstrual period, and at some point we just don't have enough eggs to be making enough estrogen to maintain the symptom status that we have before menopause. And so what you see in this is that we talk about early, peak, and late reproductive phase. When we get into the late phase, women are having more trouble actually reproducing and getting pregnant, and they may need to get into some assisted reproductive issues. The menopausal transition, we also divide into early and late, and so we talk about a perimenopause phase, and then the postmenopause is when things are really, you're on the other side of that issue. Now, one of the strongest predictors of menopause is this irregular menstruation, and it's varied by different individuals, so you can get a lighter bleed, a heavier bleed, longer bleed, shorter bleed. Many women will talk to you about the excessive bleeding that they had leading into menopause. And about 90% of women actually will have 4 to 8 years where they're not recognizing that their menstrual periods really have been changing from when they were in their peak reproductive years. Now, the bad news for those of you who want to know, is this ever going to stop, is that the average, these are looking at a very wide range of about how long hot flushes continue, and what you see is the highest column here is 3 years. So in this particular sample, 3 years was the peak, but there's a lot around that peak, plus or minus two or 3 years. So it's not uncommon for women to be experiencing this for 5 and 6 years. But what you also see on this is that there's a group of women that continue having these hot flushes on out probably forever. We don't know the data. There's very good data from Sweden showing that about 9% of women age 70 still have hot flushes. Now, I will tell you, I'll give you a little preface of the WHI. You're going to hear a little bit about the Women's Health Initiative as I proceed, is that we have evidence now that if women who are older who have hot flushes start hormones at older ages, they have the worst outcomes. And so it's not really something that we would recommend for a woman who's 70 to start hormones. We have lots of evidence now that the older you are, the more serious some of the complications are. And so that's a different physiology, one that has not been studied very well, and one that we really need to study. We need to understand hot flushes, especially in women who continue to have them. So it's a big area of under-researched questions. Now, when we talk about hot flushes, there are some differences by race ethnicity. It's highest in African American women and Hispanic women. This may relate to the fact that it's also highest in women who are overweight and obese, and we have a kind of a distribution curve that has higher obesity in African American Hispanics. It's also higher in Caucasians than it is in Chinese, and that also that particular sample that was looking at these data only had Chinese. It didn't have all the other Asian groups. So I mentioned age. It's actually worse when you're younger. The older you are, they aren't as frequent. It's worse the heavier you are. There is a relationship with passive smoking. History of premenstrual symptoms seems to be related to this. Use of over-the-counter pain medications. Something to realize with associations is they're not necessarily causality, that basically these are associations and it's not clear what comes first in that particular issue. It's also higher with certain comorbidities and with stress. Now, in terms of, before we get into the hormone use, what are some of the things that you can do? And one of them is trying to figure out how we actually deal with this temperature issue. And I can tell you that we're doing some research here at Stanford, actually looking at Craig Heller's glove that cools you put your hand in a glove and you can cool off your core temperature. We're looking into that. There's some research being done now to see if exercise actually can make a difference. There's research being done on paced respirations. There's some signal that it might be effective, and relaxing activities in general. So there's a lot of studies now going on trying to look for non-hormone ways of dealing with hot flushes. And I will tell you that avoiding triggers, and actually it's something that we talk about cognitive behavioral therapy for menopause, some of the triggers seem to be spicy foods, hot drinks, hot soups, caffeine, alcohol. And I put in turtleneck sweaters. That was certainly my experience. I put them away for 3 years, and now I wear lots of turtlenecks again. So that tells you where I am. Non-prescription remedies. People always ask me about phytoestrogens, soy, isoflavones, and basically these studies have not shown to be, they have not proven to be effective in placebo-controlled trials. But I will tell you that part of the problem with that is we use the definition in these trials that are imposed upon drug studies, which is that a woman has to be 12 months past her last menstrual cycle to qualify for these studies, to get the FDA indication. And what we know is that the worst hot flushes are before you have that terminal bleed, that basically the worst hot flushes are in this phase where we don't have good data, and that's when a lot of women find relief from using these products. And so I hear lots of women telling me, it works for me, and I feel like, well, we just haven't done the right study to really demonstrate that. And so there is a lot of interest now in studying perimenopausal women and not waiting until we're talking about the truly postmenopausal woman. That also is true for black cohosh and vitamin E. These have not proven to be effective in placebo-controlled trials, but those have those definitions. And so it may be that we really need to get a lot more data on that first 12 months. And similarly with dongqi, ginseng, evening primrose, all of these have been tested and they're not proving to be effective with that rigid definition. I put at the bottom bioidentical hormones. Lots of women ask me about that, and I can just tell you we do not have the research database to back up the claims or to refute them. So at this point, I think we just have to be open-minded about it, but what you should understand is that the claims have not been backed up. So we don't have scientific data to support the idea that they're safer or the idea that they're better. And something to recognize is that when we talk about bioidentical, almost all the estrogens that we talk about have been synthesized from South American yams, which is a very great phytoestrogen, and you can make a chemically identical product from a yam, and the question is, that is bioidentical, but is it the same? And so I think most people just want to distinguish it from conjugated equine estrogen, which is, in fact, extracted from pregnant horse urine. And I think that idea offends many people. That is the most commonly used hormone. So to say one last thing about lifestyle, I think that when we talk about clinically managing hot flushes, most people do encourage these lifestyle approaches, and I think our new theme is wait it out, which is very different from a decade ago when we were encouraging women to go on hormones whether they had hot flushes or not. And that's really where WHI has shifted our clinical practice. It is the case that if we actually say what is FDA approved to manage hot flushes, hormone therapy is still the single FDA approved entity. It is considered the gold standard. So if we get into comparative effectiveness research to see does this bioidentical hormone compare, we would have to compare it with the FDA-approved ones. That said, there are products that are approved for other purposes that have been prescribed to help women with hot flushes, including antidepressants. So SSRIs, venlafaxine and paroxetine and gabapentin actually have proven to be effective in placebo-controlled trials for hot flushes. And it's not something that someone's going to recommend for that single purpose, but if in fact you're taking it, it's what I call a twofer. You could get two benefits out of one. Similarly, but progestins at very large doses, this does tend to make women cry, so high-dose progestin is not particularly helpful if you're dealing with mood disorders and you're just trying to get rid of your hot flushes. So I also want to mention the bone loss issue. Something to see on this particular slide is that both men and women achieve their peak bone density in the course of their teen and early 20 years. You're building up your bone, you peak, and then you start decreasing. And so both men and women have a decline in bone mineral density, but women have this accelerated, temporary, transitory accelerated loss associated with the reduction of their estrogen. And then after that 3 to 5 year period of accelerated loss, you resume the slow, steady loss that is also seen in men. And when we talk about the midlife woman, the midlife woman is mostly experiencing vasomotor symptoms. We don't actually see appreciable loss of bone mineral density to the point where we start to talk about osteoporosis. And in fact, we don't actually even recommend that you get a bone mineral density test until you're 65, unless you have family history and the risk factors for osteoporosis. So we don't recommend getting that at menopause, even for a baseline. But it is the case that as we move on past the 55 plus range, we start to then see these vertebral fractures that eventually shorten a woman because you're just collapsing the vertebrae to the point where when we get into the 75 plus, on this particular slide, you see a woman who clearly has kyphosis because of vertebral fractures, and that's the woman now that is also at the highest risk for hip fractures and for falls, and it may even relate to the fact that that particular person, if you look at that, is not a very stable person. That's a woman ready to fall easily. But she has a cane, so that's good. Okay, so what are the risk factors for osteoporosis? Age is clearly an important one. If you go through menopause early, which, by the way, smoking shortens your time to menopause basically about 3 years. Smokers go through menopause about 3 years earlier than non-smokers. If you've had some phase during your active reproductive life of primary or secondary amenorrhea, which is your menstrual cycles have stopped, which is something that we worry about with high-powered women athletes. That's one cause that and then we question whether it's really causal or whether there's a predisposition there. But if you do go through a phase where you're just not menstruating, that means you're not ovulating and you're not producing estrogen. So that's a point where you could have this premature loss of bone density. To just say a few more, family history, low body weight actually is associated with higher risk for osteoporosis. I already mentioned smoking, excessive alcohol intake. We don't have very good evidence that alcohol actually changes bone mineral density as much as it increases your risk of falling, and so that's the real issue there. Similarly, with poor visual acuity, I think the relationship there is that you're going to bump into things and fall. So we do recommend fall-proofing your house, get rid of rugs that slip out, and I will say that neuromuscular disorders, but also just being immobilized and being weak. If you can't get up from a chair that doesn't have arms without falling and tipping, you're at danger. And so those are the kinds of reasons that we talk about. Get your muscles stronger, your thigh muscles in particular. Now, in terms of calcium and vitamin D, there's a lot of interest in vitamin D right now. The studies are really kind of underway. Very recently, the Institute of Medicine upped the minimum dose of vitamin D for women who are younger than 70 to 600 international units. It previously was 400, but they didn't go all the way up to 800, and they certainly didn't go up to 2,000. So a lot of you are hearing, and a lot of you are getting your serum vitamin D levels measured these days. This is kind of a popular thing happening, and most of you end up being insufficient or inadequate. It seems to be something that we really need to get the scientific base on, but these claims that we need to be going up to 2,000 is not even what the Institute of Medicine recommends. So here you see these guidelines, and I will tell you that in the Women's Health Initiative, we had a huge calcium vitamin D study that did show that for women 60 and over, calcium supplements made a difference, but that actually for women in the midlife age, it didn't make a difference. And in fact, they actually were more fractures, but the numbers were so small because we don't expect women to be having fractures before age 65, really. I will just make one quick plug for exercise for bones. I think it prevents bone loss. I think it's really important for fall prevention because we need to be able to just stand and not fall. But also, it may decrease hot flushes. There's a study going on right now. We have evidence that it improves mood and sleep. It does help maintain body weight. Preventing weight gain. There's some evidence that it supports joint and muscle flexibility and lots of other factors. So now I want to say something about the hormone story, and you'll see in quotes HRT. Most students will know if I'm grading your papers that if you say HRT, I say we don't use the R anymore. We don't use the R. We don't have the idea that you need to replace estrogen. And so that's where the HRT, and it was very effective for sales to make everyone think that you're deficient and you need this. But we went into this study, the Women's Health Initiative, with some other trial data. Hers is mentioned here. It was a study of women with heart disease. The prevailing belief at the time that we started the HERS study was that a woman with heart disease must go on hormones to prevent a second heart attack, and HERS actually proved beyond a shadow of a doubt that it does not prevent the heart attack, and in fact, it precipitates it, so that there were many more heart attacks in the first year of starting it. But there still was this question about primary prevention. And I will make the caveat that we're absolutely clear that it's helpful for hot flushes, and that for a woman who's got severe hot flushes, nobody in the WHI would recommend that you don't take hormones. They're not resistant to the idea that hormones are valuable for hot flushes. But the issue is that that's just for that purpose. It's a short time of your life. We're talking 2 to 3 years. We're not talking the rest of your life. But they were talking the rest of your life before we started this trial. So going into 2000, we had lots of push on the part of the clinical community to put women on hormones to prevent heart disease and to look at these other issues. So it was a puzzle. We didn't really have enough information, and I will just, I won't let you read this whole puzzle. What I'm going to do is go to what the hypotheses were in a schematic way. So basically, when we talk about balancing risks and benefits, that's why I'm going to use this little balance here, that we had this expected belief, or this belief in benefit to heart disease. And from the observational literature, we expected this to be quite high, that we would have 30% reduction in heart disease if we could get women onto the hormone therapy. We had anticipated risk of breast cancer. The epidemiological literature was suggesting that we would increase breast cancer if women go on estrogen or estrogen and progestin. We didn't know about stroke. The data were kind of all over the place. We did expect benefit for bone. and also because of heart disease, overall mortality, and we did expect harm for blood clots based on the oral contraceptive literature, and based on the oral contraceptive literature from the beginning when it was very high dose and we were seeing young women getting cardiovascular assaults that we never expected in an age group like that. So the first thing to just let you know is there are really two hormone trials, and it's been almost impossible to get the media to understand that. So you keep hearing hormones, and you keep getting the idea that it's the same story. But in fact, if a woman has had a hysterectomy, the clinical practice would be that you would give her just estrogen. And if she still has her uterus, you would give her estrogen and progestin, because we know estrogen increases cancer of the uterus, unless it's opposed by progestin. And so in the Women's Health Initiative, we did what clinical practice would do. We essentially randomized women based on whether they had a uterus or not into either an estrogen and progestin trial, the combined therapy trial, or an estrogen-only trial. And I'm going to present the results from the trials separate in the hope that you will get the fact that the results differ depending on these two populations of women. I will also quickly make the point that the two populations of women differ dramatically. And one of the differences is that whatever the criteria are for recommending a hysterectomy go into basically separating a group of women who, as a group, tend to be more overweight, more obese, they've already had more children. There's a number of factors that separate them into a higher risk group. So they're higher risk for heart disease, whether they take hormones or not. But in the estrogen and progestin group, the first thing that happened was that trial showed a very interesting phenomenon, and that is that breast cancer risk increased within 5 years. And this was very unexpected to see breast cancer show up so quickly. And again, it was the combined estrogen and progestin. Now, that would not have stopped this trial, because the rules of the Women's Health Initiative trial were that as long as the overall picture of benefit counterbalanced the harm, the trial would continue. We wanted to keep the balance going, and the stopping rules were set up where harm, if one thing hit the a priori, so we had the rules before we started the trial, if it hit that rule, we wouldn't stop the trial just for that endpoint. So breast cancer hit, but by that time we already had enough benefit to fractures being reduced, and we actually had the surprise, colorectal cancer being reduced, that those would have balanced out the balance and we would have continued the trial. But the problem was the hypothesis, which was actually the basis of trying to get all the women in this country on hormones, was wrong. It did not prevent heart disease, and it increased stroke. It increased heart attacks, it increased stroke, and then the blood clots that we expected were also there. So it was clearly a picture of harm over benefit, and the idea that we should be encouraging every woman in this country who has a uterus to go on estrogen and progestin was proven to be absolutely the wrong thing to do from a prevention perspective. Now, in fact, for estrogen only, where we really had a much better database going into it, so a lot was extrapolated from the epidemiology that we had about estrogen only. The first thing I'll tell you, in the estrogen only trial, which again is the trial for women who had a hysterectomy and who actually were at higher risk for heart disease independent of the hormones, just based on whatever criteria. And one of the criteria is excessive bleeding, which happens if you're overweight. You actually have more estrogen on board, and so that does stimulate the uterus. And so that is a reason that many women get a hysterectomy. But I'll first of all point out that in the estrogen-only trial, we did not see any effect on heart disease in the study population overall, or on breast cancer in terms of by the time the trial was stopped. But this trial was stopped not really because of harm or benefit equaling. It came out completely neutral, but we had clearly increased strokes and clearly decreased osteoporotic fractures and hip fractures. So those two things balance each other out, but the study was being funded by the National Heart, Lung, Blood Institute. They could not bring themselves to continue a study that clearly was increasing stroke. And so that's the reason that study was stopped. So when we look at these two trials, they actually were very consistent in a number of ways. No benefit for heart disease. So the idea that this is the way to prevent heart disease was wrong. And for the estrogen and progestin trial, there clearly was early harm. There were more heart attacks in the first year in the women with a uterus. Strokes and blood clots were harmed. Fractures were benefited very much on both groups. And I didn't bring the data, I didn't show you anything about dementia, but we actually had a study on the side of older women, and it was a huge study, 7,000 women, 7,000 women who were the participants of the trial, looking at the issue of dementia, which many people were saying you need to take estrogen to prevent dementia. And in fact, that turned out not to be true. In fact, we saw more dementia. Now, the trial results were very different with respect to cancer, both breast cancer and colorectal cancer, where in one case estrogen and progestin increased breast cancer, did not increase, estrogen only did not, and colorectal cancer was decreased with estrogen and progestin and no effect. So I've already got my signal, and I'm going to have to just say we solved that puzzle. In the directions of a very different message. And I'm going to have to go very quickly now because I do have some more slides. The question then was, what happens when you stop? Everybody stopped. So I'll just quickly tell you that for the estrogen and progestin story, when they stopped, the risk for cardiovascular disappeared, the benefit to bone was completely gone. The idea that you should take hormones when you're 50 so that you won't get a fracture when you're 70 is completely wrong. It's not going to happen. There's no benefit left. I will tell you that we were a little surprised that our cancer results suggested that there still were more cancers because there was a huge national study that looked at the impact of women stopping hormones, and I think I can show you. Here's what happened in the nation. They dropped their hormone use after WHI, and what the SEER data showed is that breast cancer dropped in this country very significantly. So it went on very regularly, year. Here they stopped their hormones in the country and breast cancer, and it was estrogen receptive positive breast cancer. So we actually looked in our study to see, do we really have that? And what we had was, while they were on hormones, breast cancer was increasing and went up twofold higher. And when they stopped the hormones, it decreased. And so even though there still were more breast cancers in this post phase, it was really evidence that it was decreasing. And the main reason why we still were getting them, and this is something that's really important, is that in estrogen and progestin, what we learned is that your breast density is increased when you take estrogen and progestin, so that the mammography is not very sensitive, and you can't find the tumors until they're bigger and they've invaded more area. And so that basically this is showing you that in the first 6 months, there's still this huge difference in abnormal mammograms, and it's really 18 months after stopping that your breasts are now at a point where the mammograms can pick up those tumors. And so that's a really interesting issue. And we actually had an observational study where we could look at kind of what happened on women on their own. Women who on their own were taking estrogen and progestin had twofold higher breast cancer until they dropped their hormones, which you see here, and then just like the country, a decrease. So there's no question cause and effect. I'll just quickly tell you that what came out 2 weeks ago, or 3 weeks ago now, was the estrogen-only results from after stopping. And in a nutshell, I focused on what happened during the intervention. When they stopped their hormones, the stroke risk went away, the DVTs, there were actually fewer of them. Breast cancer is one I need to just quickly tell you. What we learned is that estrogen only in this population did not increase breast cancer, it significantly decreased it. And to just remind you, women were on those hormones for about 5 years and then they stopped. So we're not saying you should go on it the rest of your life, but we're basically saying that going on it at the time of menopause when you're really uncomfortable is probably not a dangerous thing. It's certainly not something that we're worried about, estrogen only, with women who have hysterectomy. So we're not saying go get a hysterectomy so you can take it. And then there's one other little piece I need to tell you, and this is the real news, and I'm sorry that I'm running over, but the real news is that when you break this down by age group, so if we talk about the menopausal age women, so here's your 50 to 59 women going into the study, we actually did see what the observational literature had suggested, that in young women who go on these hormones short term, they actually have a decrease in heart disease. They come off it, so we're not saying stay on it, but older women who go on those hormones, which is what the country was doing, will have a significant increase. And so the bottom line is we do need to start thinking differently about managing menopause. Women who are younger probably will get benefits, but no evidence that they should stay on those hormones. This is estrogen only. It's not estrogen and progestin, which is all bad as far as I'm concerned, except for hip fracture. Breast cancers, it's clearly fine, and that the overall picture is that those women who went on the estrogen only at around 50, if you look at them 10 years later, they're better off than if they hadn't gone on it. But older women who go on it at that time are worse off. And so it's a very mixed message. It's one that the media cannot get right. And hopefully I didn't confuse you too much, so you have it right. I will tell you the current indications are to go on if you need to go on hormones, I'm still recommending lifestyle, but short-term lower dose for hot flushes. If the only thing wrong with you is that you have dryness, vaginal dryness, then the recommendation is topical, not systemic. And then for bones, we don't recommend estrogen or estrogen and progestin as the first wave. We actually, the recommendations are trying other products. They haven't been around as long, and so I think we're going to keep hearing up and down stories about those other products as well. So with that, I'm finished. Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.